The views expressed in this podcast are my own and those of my guests. They do not represent or reflect those of UCSF Health or my professional and clinical roles there. The content is intended for informational purposes only and is not medical advice. Please consult a qualified healthcare professional for specific medical guidance. Welcome back to In the Loop with Nadja Wlasiuk, where we break down important healthcare topics to keep you informed and empowered. Today's episode is one that's both professional and deeply personal for me. We're talking about preeclampsia. I've experienced it twice during my own pregnancies, and while I was fortunate to have good outcomes, I wasn't told at the time about the increased risk for heart disease, stroke, and other vascular complications later in life. That missing piece of education is one of the reasons I'm so passionate about having this conversation today. Joining me is Julie Baker Townsend, a nationally certified women's health nurse practitioner, clinical associate professor at the University of North Florida School of Nursing, and a highly respected educator and clinician. Julie earned her Bachelor of Science in Nursing at the University of North Florida, then went on to earn her Master of Science in Nursing at the University of Florida, and finally, her Doctor of Nursing Practice at the University of North Florida. She was recognized as one of the great 100 nurses of Northeast Florida in 2003. She's worked in high-risk obstetric units with Level 3 NICUs, served vulnerable and underserved populations through the health department, and now divides her time between teaching women's health at the University of North Florida School of Nursing and practicing as a women's health nurse practitioner. She is highly regarded by her students and colleagues for her clinical expertise, compassion, and unwavering dedication to advancing women's health and nursing as a whole. Not only is the topic that we're discussing very close to my heart, but Julie is also very close to my heart. She was one of my very first nursing professors and mentors. Her passion for women's health and her dedication to educating both patients and future clinicians have left a lasting impact on me, not just as a nurse practitioner, but as a woman who's experienced preeclampsia firsthand. In this conversation, we'll explore what preeclampsia is, how to recognize early warning signs, what treatment looks like, and the often overlooked connection between preeclampsia and long-term cardiovascular health. It's almost like you get a peek inside one of her lectures at the University of North Florida. Whether you've been through it yourself, care for patients at risk, or just want to better understand this condition, this episode offers both insight and practical steps you can take for prevention and early detection. Let's get started. Thank you so much for joining us today. Can you tell us a little bit about your journey in becoming a women's health nurse practitioner and what drew you specifically to women's health?
Well, first of all, I would like to thank you for inviting me on your podcast. I'm a huge fan. I listen to them all and I learn every time. So I want to tell you, I'm very appreciative for the education that I'm getting through your podcast and to be a guest. Okay. So with that being said, let me tell you a little bit about what drew me here. It's an interesting path. So my nursing school adventure was very complex in the fact that I had thought I was going to get into the University of Florida because I had a 3.94 GPA. And I was denied admission.
Oh.
Yeah, I was denied admission and I was, devastated. But I knew that I wanted to be a nurse as soon as possible. So that took me to a place that would let me in and had great outcomes, great nurses. My dad had been in the VA, so I had known the nurses that had graduated from Lake City Community College. It's now called Gateway College. It was a very rigorous program. So I started there. I did an ADM program. While I was there, they were very, very strict. And you had to know assessment. I mean, you really, really good school. So I went to my clinicals for women's health. And on the very first day of my clinical experience, I had a woman come in via ambulance from Alachua, and she had just a UTI. That's what they said on EMS when they brought her in. Unfortunately, when she got there, she had a severe fever. The baby was already sick. She was septic. She was 18 years old. And by the end of my shift, she had died of sepsis and acute respiratory distress
Oh
failure.
my gosh.
Right. So I was like, how does this happen? How do these young women who are in great shape die during pregnancy? So that really sparked my interest. So that propelled me to want to do women's health. I did a year of med search, like most nurses do, and got a lot of great experience. And then I went to a high risk obstetric unit in Jacksonville, Florida. And so they had a high level NICU. We had critical care obstetric
Hmm.
nurses, and I trained for that. So that really made me interested in the really, really high risk patient.
Hmm.
So from that point, I did labor and delivery high risk. I went out and opened up a brand new obstetric unit that was an LDRP, that was a satellite unit, and
Oh,
then
oh,
I
real quick, what is an LDRP for those people who
oh,
aren't
very
familiar
good.
with that?
Yes. So on our high risk units, we do labor and
Hmm.
delivery. And then on our lower risk units, we do labor, delivery, recovery, and postpartum. So the patient can deliver in one room, stay in the same room the whole visit. It's really a great model of care. They get very consistent nursing care, usually the same nurse. It's a great model. However, when it's a lower risk unit, you don't have the backup of a high risk hospital. So you have to be a critical
Hmm.
thinker, and you have to be very good assessment and an early interventionalist, because you don't have the backup. It's you. And to call backup, people have to come in from outside of the
Hmm.
hospital. So I did that, loved that. Did that for 8 years. I said, I could probably give more back to the population. I love the indigent
Hmm.
population. I love the Medicaid, Medicare, no prenatal care, all of that population. So I went to nurse practitioner school at University of Florida. I got a degree in women's health. Then I became a women's health nurse practitioner. Started working for the health department. Still worked in labor and delivery. Couldn't pull myself away because I just love that type of care. And then I moved to academia after I worked for many years as a nurse practitioner in the health department. And now I work in the clinic and I do GYN, not just OBGYN as I had done before. I do
Hmm.
GYN in our student health center, and I teach women's health at the University of North Florida. So I have had a very interesting and humbling experience learning all the time women's health, and I am a big advocate for strong women's health practices.
You absolutely are. And that's one thing that I have always loved about you. And, how we met with you being my women's health professor, that just shines from you. You love women's health. You love women. You love the health surrounding them. And I think that's how we connected because I definitely was in that phase of my life after I had all the babies and I was a doula and a childbirth educator as well. It was just like something that drew me to you because you had such a love for that as well. So
Yeah, we definitely both identified with those principles for sure.
definitely. But thank you for sharing your journey. And it's amazing. And I think it's really awesome that you didn't get into Florida at first, but then you did for your NP.
Yeah. It's that never let them defeat you kind of attitude. It's like I was very appreciative that I got my education at Lake City Community College. Then I went to University of North Florida for my BSN.
Hmm.
I actually feel like I was more well trained going to smaller schools. And I feel like it worked out the way it was supposed to. It was heartbreaking initially, but then, it turned out to all for the best.
Yeah, and kind of just circling back on that whole like, where you got your education piece. I mean, um, I think it's really about what you make from it, and you don't have to go to a big name school. I mean, yeah, we both went to the University of Florida, which was amazing, and I got great education there, but I got my associate's degree at Florida Community College, and then I got my BSN and DNP at UNF, and I will tell you my undergraduate experience at UNF and just professors and the quality of education and care that they put towards me. I mean, it was like I went to an Ivy League school for what I took away from it, honestly. So,
I 100% agree. I definitely think that students need to look at culture when deciding where they want to go, because I think culture is more important than name.
oh yeah, absolutely. And your self motivation, like you're gonna
Mhm.
get what you can gather from it. And if you have a good attitude, and you can get A plus education from anywhere if you really work on it, and it's quality. Like, I don't know. We could talk about that for days, but that's not the
For
topic of
sure.
this podcast. All right. So, um, today we are talking about preeclampsia. And so I think I would like to share a little bit about why this is important to me. And then I'm going to let you share all of the professional clinical aspect of it, if that is okay. Okay,
Perfect.
awesome. So, preeclampsia is something that I have lived through twice. I had four babies. And the last two, I developed preeclampsia. With my daughter, Nineveh, she was really a mild case where we had just seen like my blood pressure go up a little bit. I had a little bit of protein in my urine, and I was getting a little bit more swollen than normal. We did end up inducing her. She was an easy labor. Everything was fine. I had no complications afterwards, but I do remember like, oh, I have preeclampsia. I have to have all this extra testing. And this was before I was a clinician. And so that was my first experience with it. And then I got pregnant again about 2 years later, and I had very severe preeclampsia. I didn't have any seizures or anything like that, but I did have to get induced. And there were other complications that happened with just positioning and different things during the labor, and I ended up hemorrhaging. But I think it was all part of the complication of preeclampsia. And this time my blood pressure was much higher, and I had a lot more symptoms, and I had to watch my blood pressure. Thankfully, I didn't have to be on any blood pressure medicine, but I was induced, and I had a really long labor, and I had the postpartum hemorrhage that was a complication, and then I had three other babies at home. And for me, what I think my biggest takeaway, now that I'm a nurse and I'm now almost 20 years out from that, oh my gosh, my baby's 20, is no one told me, Julie, that there are risks with my health moving forward after having preeclampsia. And so I think that is one of the big things of why I wanted to talk to you about this today, to share with people who may have had some level of preeclampsia and they don't know that they're at risk for vascular complications down the road. And that, I firmly believe that an ounce of prevention is worth a pound of cure. And if we as women can be um knowledgeable of that, and we can watch for that, check our blood pressure, make sure that our providers know moving forward, like, yeah, I have a history of preeclampsia. Yeah, it was 20 years ago, but I don't want to suffer complications from things that, when I was in my 20s weren't really a problem, but they can be a problem later down the road. So I feel like even in my practice, I specialize in rhythms of the heart. But if I have a woman that's coming in, I always ask, did you ever have preeclampsia? Just so that I can make sure that they let their general cardiologist know, so that that's something that can be watched for. So that's my kind of personal side of preeclampsia and why this is so close to me. But I would like to know how preeclampsia became an area of interest for you.
Well, I have to be very honest. When I went downtown to the high risk obstetric unit, and it was critical care, I learned that preeclampsia can cause horrific outcomes for the mother and for the fetus, and of course, the neonate after the fetus is born. The maternal risk, so, people can walk around without having any symptoms and be preeclamptic. And then there is no time definition on when the preeclampsia worsens. So there is no definitive time of when you start to have elevated blood pressure until the very dramatic can happen. And these are the dramatic things that can happen from preeclampsia. Moms can have seizures. They can get injured when they have a seizure. When they have a seizure, there's no oxygenation to the
Mhm.
fetus, which is very scary. Other maternal risks are abruption. The pressure can get so high that the pressure pushing the oxygen and the nutrients over to the placenta, it can blow the placenta off of the wall of the uterus, called a technical abruption. And that can kill the mom and the baby in 4 minutes. And especially if they don't have emergency C-section, they can both pass away. Also, it damages the placenta. We think that's the root cause of preeclampsia is damage to the placenta. And it can cause preterm neonates. It can cause small babies. And unfortunately, it can cause intrauterine fetal death. So when I was there, I saw all these complications over and over and over. Oh, and then the big one, postpartum hemorrhage, like you were saying. The pressure is so high going to the uterus. Of course, if there's high blood pressure going to the uterus, there's going to be more bleeding. And so that's one of our biggest risk factors for a postpartum hemorrhage. And women, they don't understand. They think, oh, the baby's out, I'm good. Unfortunately, a lot of mortality is based on that hemorrhage after they have a baby. It definitely is a complicated thing. I just want to talk about personally, I had preeclampsia and I was induced. And then I have a best friend who had preeclampsia. Unfortunately, she was like 26 weeks when she developed it. And she was very fortunate. She went in just for a routine check. She had no symptoms. She was so severe. They said, pack your stuff, go to the hospital. They gave her medication, steroids to help the baby's lungs mature. And she was born at 28 weeks. She had had it so severely that she had had a preterm birth. Fortunate, our friend lost sight in her eye for 6 months because the high pressure to her eye. She was so lucky it returned. She was also very fortunate that her baby was in the NICU for 3 or 4 months and had no adverse outcomes. And to this day, that baby made the junior high volleyball team today.
That's awesome.
Yeah, yes. And so, this baby did wonderfully. There are no signs of prematurity. She had no complications, but that's because she had access to excellent prenatal care and hospitalization. So it's definitely very close and personal to our hearts.
Yeah, absolutely. That being said, we may have given a lot more information up front, but for those who aren't familiar, what is preeclampsia and how is it diagnosed?
Okay. So it is definitely a big deal because the problem is, first of all, I just want to say that you need to have prenatal care or you need to have healthcare education to understand that you need prenatal care so that we can monitor you and monitor your blood pressure and then monitor for organ damage during your prenatal visit. So every time that you have a prenatal visit, you come see me, we take your blood pressure, we check your urine. How we know that you could have damage to your organs is when we do your urine,
Mhm.
you could have protein in your urine. And that's how we know that the pressure is high to the kidneys, just like you had said about your own personal
Mhm.
journey,
Yeah.
right? So, prenatal care is essential. Barriers to care, such as people who are fearful to go to medicine. There is a large population in America who is fearful of medical people. And so those are huge barriers. Other barriers would be economic factors or educational factors that they don't understand that pregnancy could be a huge problem for them. They think, oh, people have been doing this for years, but people have been dying. I do want to say this about preeclampsia before I talk about quickly about the
Mhm.
pathophys, but you guys, what we know is, and sorry if I say dude, because when I try to ease the students because they're on such high alert. I try to ease them and I say dudes a lot. So what I want to say is our population has greatly become more at risk for preeclampsia. Since 1980, there is a 6.7-fold increase in severe preeclampsia. And why is that? That is because we have more vascular complications than we did in 1980. And preeclampsia is a vascular
Yep.
problem. So, what is the number one reason for these vascular problems? Unfortunately, it is obesity. So, sadly, what's interesting about obesity and blood pressure is people go, I don't understand why my blood pressure increases when I'm obese. Well, there's a couple of things. Number one, the adipose tissue compresses the blood vessels.
Yeah, and adipose tissue is just fat tissue.
Yes, and it just compresses them, so it raises their blood
Yep.
pressure. So so if you lose 10 pounds, you can lower your blood pressure, so that is significant. So that's what I wanted to say first
Okay.
about that. But preeclampsia affects about 10% of all pregnancies, and it's the major cause for maternal and perinatal morbidity and mortality. It's unfortunately more common than we think. It used to be called toxemia. So when you're talking to an older patient, maybe 70 years old, 80 years old, they'll say, "Oh, I had toxemia," because that's what they used to call it. There's a much more difficult labor. We in the hospital, this is such a problem. Preeclampsia is such a high risk situation. We have drills, we have preeclampsia carts, we have hemorrhage carts, so that we can identify these people and intervene very early. Preeclampsia is just elevated blood pressure without a seizure. So, the diagnosis, you have to have a blood pressure of 140/90 on two separate occasions, 6 hours apart, with some type of organ involvement. So, it would mean you had high pressure to your brain. So, that would cause visual changes and headache. You have to have high pressure to your liver, which is an organ. So that could mean you have right upper quadrant pain, or there are changes in your labs, or high pressure to your kidneys, or your kidney enzymes are elevated. And so what causes this? So we're pretty sure there's not an exact mechanism, but we know that once the placenta is damaged, it can set off the course of preeclamptic problems and issues. And what happens is once there is ischemia to the placenta, a lot of things start to happen. You start to have vascular remolding. So the vessels actually change because they get damaged. Then you will start to have changes in the epithelium. Now, the epithelium is the outside lining of the vessel. It will then become leaky, okay, because there's vascular damage and vasospasm. So then the plasma that is inside of the blood vessel, that's actually in the blood, leaks out of the vessel, and then people get edematous. So edema is another one of the signs that people have it, because you can tell that the vessels are failing. So, and then the pressures continue to go up. The more the pressures go up, the more damage to the placenta, the more damage to the vasculature, the more damage to the organs. So now we can go into a syndrome called HELP syndrome, which is hemolysis of erythrocytes. And erythrocyte is a red blood cell. So the pressure is so high inside of the vessel, the little red blood cell hits the wall, explodes, and hemolyzes, meaning it explodes and it decreases the amount of red blood cells, thusly decreasing the amount of oxygen going to the placenta. Elevated liver enzymes because there's high pressure to the liver, and then low platelets. Because when you start to get vascular damage, the platelets line all the vessels, and now you have low circulating platelets. We need the platelets to circulate in our blood so that when we start to bleed, the platelets stop our bleeding. Well, when there's vascular damage across all the vessels, those little platelets are stuck to them, and we don't have it to stop bleeding. And then if you don't stop it there, you can go into disseminated intravascular coagulation. And at that point, we use all of our fibrin to stop our bleeding because we don't have any platelets left, and death can occur after that.
Okay, so I have a question because you were talking about, thrombocytopenia with preeclampsia, they decrease in platelets. So why is one of the treatment methods, at least one that I was placed on with that second round of preeclampsia I had, where it was a little more serious, on a baby aspirin every day?
That is a great question. If you follow the evidence, you will see that our clinical practice guidelines will say, take it, don't take it,
Mhm.
take it, don't take it. And I really think as evidence continues, we do see the positive effects of a baby aspirin. So aspirin in doses below 300 milligrams, what they do is they inactivate cyclooxygenase, which is a enzyme that suppresses the production of prostaglandins and thromboxane and inhibits inflammation and platelet aggregation. All that means is that it stops the platelets from clumping together on the walls of the
Mhm.
vessels, and it also decreases inflammation.
Okay.
The more inflammation the vessel
Mhm.
has, the more platelets stick to it.
Okay. What are the early signs and symptoms of preeclampsia?
Well, that's a great question because sometimes there are no early
Mm.
signs. Unfortunately, you have to be a major educator with your patients. So, what we see many times is the first thing that people may notice is edema. Unfortunately, it's normal to have a little bit of edema in your legs and feet because of the plasma that leaks out of the vasculature because it's so far away from your heart.
Right.
So we say it's normal to have a little bit of swelling in your feet at the end of the day when you're pregnant. Unfortunately, one of the bigger signs that we see with preeclampsia, this is a sign, not a symptom. A sign would be edema, like edema of the face, edema of the
Mhm.
hands, and then massive edema of the legs. Now, another sign would be elevated blood pressure, but you can walk around and not know you have elevated blood pressure, which is really scary, and why we need to identify people's risk factors so that we can educate them and say, hey, keep a blood pressure log.
Absolutely. Well, also on that, I educate all people on blood pressure because it's known as the silent killer. Because just like you said, there usually aren't any symptoms of high blood pressure.
Absolutely. And people think, oh, I'll know if I have high blood. No, you will not
Right,
know.
exactly.
Okay, so the signs would be the
Mhm.
edema, the high pressure. They have hyperreflexia. So they could be like if you startle them, they might jump really suddenly because their central nervous system is so irritated from the high pressure to their brain.
Mhm.
Some symptoms they may have, and this is a big one, a headache. I have a
Mhm.
headache. You do? I say, oh, they call. I tell them in prenatal care, if you have a headache, I don't care if you haven't eaten, I don't care what it is, I want you to take your blood pressure immediately if you have a headache because the headache tells us there can be high pressure to the brain. They can have some visual changes. They can have that burning on their right upper quadrant where their liver is because the pressure is so high to their
Mm.
liver, it's causing
Mhm.
damage and they start to feel pain. So blurred vision, dizziness, and then right upper quadrant pain, elevated blood pressure, and then edema.
Okay, yeah, those are, and I remember thinking like I was educated on all those things. I remember my OB saying, if you get a headache, if you notice any visual changes, if you're having any pain in, your right upper quadrant. And so really important for all pregnant women to know and that those things can be a sign of that and they should get evaluated.
Absolutely.
What are some risk factors? Like why would someone have preeclampsia and someone not have preeclampsia?
We know, like we just talked about, it's a vascular
Mhm.
disorder, right? So, if you have any vascular problems, those are big risk factors. So, obesity, hypertension, diabetes, type 1, type 2, or gestational diabetes, if you develop it during pregnancy, that can cause inflammation of the wall of the vessel. And so, that's a big one. Anything that has to do with any type of organs that are related to blood vessels, such as the
Mhm.
kidneys. If you have kidney disease, chronic kidney disease is the big one. Of course, smoking. We know that smoking or drug use can cause the vessel to constrict and can cause damage. We know that people with poor physical activity or inactivity, exercise dilates your blood vessels and it causes your blood vessels to be healthy. So if they have any of that, they're at risk. If they've had pregnancy after pregnancy after pregnancy, they're at risk. Short intervals or long intervals or first baby. Those are big ones. Assisted reproductive technology. So if you had in vitro fertilization, that makes you high risk. High levels of stress because you have more cortisol, that makes your blood vessels constrict. Some other things that are non-modifiable that you have no control over would be like your first baby, history of preeclampsia. So if you have a history, that's the strongest predictor that you're going to have it again.
Yeah.
A family history, multiple gestation. This is interesting. So we know that when you get pregnant, you gain about 1,500 extra milliliters of blood in your body. So that puts more pressure on your heart and more pressure on the vasculature, which can cause inflammation of the vasculature. Well, when you have twins or triplets, it can double or triple that amount. That's why it can cause major problems with your heart. I have never seen a woman that was pregnant with four. I've seen many women, well, I wouldn't say many, I'd say 10 women pregnant with four babies. I saw one that was pregnant with five. You can't walk away from that kind of situation without serious risk for postpartum cardiomyopathy, meaning there was so much blood in your body, your heart had a hard time pumping it. And now you have a little bit of damage to your heart. So if you have multiple gestation, if you're under 18 or over 35, African American, autoimmune diseases such as lupus, which is a disease of the vasculature, that can cause it, and then thrombophilia. So if you already have problems with platelets, it can cause even greater issues.
Wow, that's incredible. And remember when I was working inpatient cardiology, having a few patients who had postpartum cardiomyopathy, and it is such a interesting and scary thing because you are essentially a healthy person, and then suddenly and without warning, your heart's like, "Hi, I am struggling," and it's like, a lot of times you're dealing with having this new baby, and then your heart isn't working right, and it's a lot for someone to handle.
I do want to tell you this. I've had patients who've had postpartum cardiomyopathy with one baby, not
Yeah.
just, I talk about multiples really increase your risk, but you can have it so severely that you can walk away with postpartum cardiomyopathy with severe preeclampsia. I did talk about the minor preeclampsia, but I do want to say that severe preeclampsia with ominous features is when your blood pressure on one account is 160 over 110 on just one blood pressure reading and then some type of organ involvement, all those symptoms, we immediately hospitalize them. We don't wait 6
Right.
hours. We immediately go start treatments, start our protocols, start our drills, and they're on high alert for all of those complications, such as problems with the placenta, abruption, all of those
Mhm.
things.
So if someone came into the office and they had what you saw as preeclampsia, um, maybe not severe, but just like their blood pressure was elevated 140 over 90 on two separate occasions, more than 6 hours apart, and they had say like for me, mine was I had protein in my urine and I had that hyperexcitability. I remember being hyper
Mhm.
excitable and I had so much edema. I even remember you saying this I think you said this in one of your lectures in undergrad, something about the swelling, the edema, that if you didn't know what the patient looked like before anything, you have them show their driver's license.
Always. That's one of my favorite teaching tools. I'll say, ask the patient on initial assessment to see their driver's license picture, and periorbital edema is noticeable on a preeclamptic patient. Now, a lot of women, their face will get a little bit bigger because they had a little bit of weight gain, but they'll have all that swelling in their face. But you're exactly right. Those are big ones. But what would I do with them? So I caught them. I'm sending them to the hospital.
Okay.
So they go to the hospital and they'll go to triage and we monitor their baby, right? To make sure their baby is okay. We do a non-stress test to make sure the placenta is functioning. And then we'll do a series of labs. We'll do blood work to see if any of the kidneys, the liver, the platelets, or the red blood cells are affected. And do a good assessment on them. And usually they let them go. After that, we really educate them. We see them more often. We do higher risk assessments. Bed rest doesn't work for them, but we do tell them, and people want to say, oh, no salt. Well, you do need salt. So we just say don't indulge in a lot of high salt snacks because we know it can drive your pressures up with fluid retention. But we have them, decrease their stress. We have them, monitor their blood pressures, and we just really stay on top of them. Once they start getting organ involvement or their blood pressure starts creeping up, we get closer to 38 weeks, then we start thinking about induction. And we try not to do inductions. I mean, that's one of the things that we try not to do. But if they need a medical induction for this, here's kind of the guidelines. If you're 20 weeks pregnant and this preeclampsia is going to kill you, right? It's going to cause your brain stem to swell and it's going to herniate your brain stem and it's going to kill you. We're going to do an emergency section to save your life, right? So that's kind of the rule of thumb, is that whenever it gets so severe, we're going to deliver, because delivery is the cure. Delivery is the cure for preeclampsia.
Okay.
We'll talk about postpartum preeclampsia later, but our whole goal is to get you in, protect the baby. We give the baby some steroids to help the lungs. Get mom and baby delivered, make sure they're both safe, watch for postpartum hemorrhage. And then one of the big things we do too is we give them the steroids, but we give them a medication called magnesium sulfate during labor, or as soon as they get there. It relaxes the central nervous system and prevents them from having a seizure. That's the number one action. As a side effect, it relaxes the smooth blood vessels and lowers their blood pressure a little bit. So it's like a 2-for-1. We keep them on that 24 hours after delivery. And the biggest thing is, one of the biggest evidence that we have with preeclampsia is it protects the fetal brain from brain damage. Isn't that amazing? It protects the fetal brain. So even when they're born early, it can be a major protector.
That is amazing. The downside of magnesium is it makes you feel like hot garbage when you get it.
Hot garbage. It makes you nauseous. And so what's interesting is how it makes all your little terminal capillaries dilate, and it feels like your skin is on fire, doesn't it?
I just remember feeling like I don't remember the skin on fire. I just remember it really making me feel slowed down and sluggish and
because it relaxes everything. It's a smooth muscle relaxer. It relaxes your brain. They vomit a lot, so we try to tell them, just kind of clear liquids. But one of my favorite nursing interventions is to get in there and give them a good bath, like scrub them down, warm hot water, and get them nice and clean, because they feel so bad. They're in that bed, So I love to put lotion on them and clean them up really well and do their hair and just make them feel better because they feel so bad.
Yeah, and can I tell you personally, like, when I had to go through this, I was so fortunate to have such great nursing staff around me, and the midwife that I had, and this was at a naval hospital, mind you. So I'm shocked that it was my experience, but they knew how terrible it is to have to use a bedpan, and would let me, because I had a doula and I had, my nurse would come in, they would help me use the actual bedside commode instead of a bedpan, because for some reason in my 20s I could not use the bedpan to save my life. I was like, well, I'm not going.
I'll just hold it.
Right.
Yes.
But they helped me to get out of bed, because you are at high risk for falls when you're on magnesium, because like you said, it slows down everything. It kind of just Yeah, you really you can't get out of bed, which is miserable for someone like me. When I labor, I am like a busybody, have to move, keep going. That helps relieve
Love
my
that.
pain. But then I'm like, now I'm
Yes.
strapped in the bed and I'm getting Pitocin and I'm
Ugh,
like, what the heck?
ugh.
What the heck?
Awful. Intervention after intervention. That's one thing I want to say is it does relax the smooth muscle of the uterus. So the contractions are not as effective. So many times once you're on magnesium, you're on Pitocin. And then yeah, it's like we have to do, constant fetal monitoring. So now you're on the
Yep.
monitor. Now you're in the bed. So we love patients to walk around, to not be on the monitor all the time, to get in the shower, to do all the things. And I do feel for these patients because they're so at such high risk. We have to do major intensive monitoring on them, and they're on these
Yeah, because
medications.
preeclampsia is absolutely life-threatening.
Life threatening for
Yeah,
both.
and so
Yes.
we definitely need to have another episode where we just talk about normal labor and delivery, but
For sure. For
we
sure.
started
Yes.
with the big one. So
The big one.
so okay, so we do the magnesium. We know that delivery is the cure. Anything else from like a provider standpoint or a nursing standpoint, and then anything that like the pregnant moms need to be aware of?
Really, it's about education. To be very honest, we need to start educating women in school about
Hmm.
pregnancy, especially folic acid
Yes.
to prevent neurotube defects such as spina bifida, small brain, which is called microcephaly, no brain, which is called
Hmm.
anencephaly. So it's so important, and they need to be educated on that. They need to be educated on the risk during pregnancy for preeclampsia, what it is, and how to monitor it so that these women know all of these things prior to getting pregnant. Because once they're pregnant and they have those risk factors, it can be a major issue,
Yeah.
right? So it's really about education. And one of the things I love about being a nurse practitioner is I do a lot of diagnosing, I do a lot of management of problems and care, but what I absolutely love is educating the patient. So I'd love to say, look, watch for this, watch for that, check your blood pressures, be your best advocate. And that's one of the things I always say to my patient. You are your best advocate for your health. No one is going to look after your health like you will. So I want you to be a champion for your health. You check your blood pressure, you look at your edema, you watch your weight gain. We tell them we really don't want to generally see a weight gain of more than like 5. If we see 5 pounds in a
Hmm.
week, we know that a lot of that is
Yeah.
fluid. It's, so we know that they're at super high risk and we need to do a workup. So we kind of tell them that too as well.
It's like our heart failure patients. If
Oh,
you
yes,
gotta watch
exactly.
I mean, it's essentially it feels very similar to that, even though it's a different
Well,
course. Yeah.
okay, so yours is with your heart failure patients, it's muscles. With our preeclampsia patients, it's vessels
Yep.
leaking,
Yep.
right?
Yep.
It's the same thing, but a different root
Yeah.
cause.
Yeah. So what someone can expect if they have preeclampsia is that, frequent monitoring, assessment, these labs, definitely, hopefully getting an education. Um, and then if they're close enough and it's safe for delivery, they come in and they, get induced, get magnesium, have the baby. They're on magnesium afterwards for 24 hours. And then what about like postpartum preeclampsia? What do we have to look for and how do you treat this?
This is one of the saddest things that can happen. So, for many years, they said, of course, delivery is the
Hmm.
cure. So, our clinical practice guidelines really pointed us to delivering this patient. When there was a subset of patients with preeclampsia that developed it
Hmm.
postpartum. Now, I had a student who was a nurse practitioner I was taking students to clinic. The mother was in charge. The mother says to me, "Hey, Julie, listen, my former student, her daughter, let's call her Sally. Sally is 2 weeks postpartum and she woke up with a headache and severe swelling. And I said, she needs to go immediately to the ER. It could be postpartum preeclampsia. And she goes there and they dismiss her and send her home.
Oh,
She calls back and I said, tell her to go now to the high risk hospital and go back to the ER. And here's the clinical practice guideline that the American College of Gynecology and Obstetricians and Gynecology put out that says that it can occur up to 6 weeks postpartum. A late postpartum preeclampsia is after 48 hours, but before 6 weeks, which is what she had. And here's the kicker. It accounts for 15 to 25% of all preeclampsia cases.
that is a huge number.
Huge. So she takes that document with her and gives it to the provider. They do a workup. She's got severe preeclampsia.
Wow.
They put her in the hospital, put her on MAG for 48 hours so she wouldn't have a seizure and to try to stabilize her. And then they had to put her on 3 different blood pressure medications to then get her available for discharge. They point to the pathophys with this remnants of the placenta in the uterus. So
Okay.
we don't know exactly the cause, but we think it's from even microscopic portions of the placenta, right? Because it's still there, and we know that placental ischemia can cause this. So it's a serious thing that people don't even know about. A lot of patients are not even educated on this in their prenatal care. The hospitals do an amazing job educating with this. And there's a new evidence-based project where they're giving the patients a bracelet that talks about postpartum preeclampsia if they meet the criteria of the risk factors that says, call the doctor if. And that they wear this little bracelet for 6 weeks. Love it. So it triggers them to remember to keep themselves safe.
Yeah. And like for me, I feel like I don't even care if you have the risk factors or not. I think everyone who delivers a baby should just know that stuff because, like, I mean, it can be fatal.
Fatal.
Yeah.
And they don't realize it. They can have a seizure driving a car.
Right. And
There's so many horrible things.
yeah, and you think, I mean, I had all my babies before I turned 25. Like back then I thought I was invincible. I was young and healthy. I didn't take any prescription medication, like, and you don't think like you're going to be like having your grandma's pill box and like something's wrong with you. And so you don't even take this stuff seriously. And it's a serious thing,
Very serious. Yeah. And what's even, talk about postpartum preeclampsia, but after you have preeclampsia, these women now, if you have preeclampsia, you're 2 to 4 times at higher risk for developing chronic hypertension, 2 to 3 times at higher risk for ischemic heart disease or stroke, and 4 to 5 times higher risk of heart failure later in life.
Yes, thank you for bringing that up because that is something that is not talked about in cardiology often enough. Women are undertreated and underdiagnosed and things like that. Like it's a thing. Like I've never had someone like really talk about it, and I try to keep talking about it, and I network with women in cardiology, and like we really have to talk about it because these women are going to come back and have all these problems, and they could have headed off of the past by knowing like, hey, I have preeclampsia. I want to continue screening for these things so that, I can keep myself very healthy as opposed to like coming in an acute heart failure exacerbation for the first time in the hospital and, having your ejection fraction in the toilet.
Yeah, I do have to tell you that, like with cardiomyopathy, but what's also interesting is I hang out with a lot of AFib nerds. My 2 besties and my third bestie, who is actually a student with one of my other besties who is an AFib nurse practitioner. What's interesting is that you have a modest elevation for electrical problems or AFib after you have preeclampsia. Isn't that fascinating?
It absolutely is. And it's something that no one Well, at least back when I was having babies, like, nobody talked about it. No one told me I was
Right.
gonna have these things. I learned it from going to nursing school. So and it
Yes.
surprised me even going into practice that, like, it's just something that's really not talked about, and so I want this episode to raise awareness for that. I want to use it in my daily practice as a electrophysiology nurse practitioner to talk to the women that I take care of and say, "Hey, did you have preeclampsia? Did you know this? Let's keep an eye on it," you know?
Absolutely. And your Broken Heart podcast, I think about that so much about alcohol and heartbreak
Mhm,
and how it can trigger, AFib. And then I think about this and I think about how many women are affected and how many women suffer heartbreak and use alcohol as an
mhm.
antidepressant or you know and so it makes me really cognizant and very acutely aware of how it really elevates their heart risk.
Yeah, yeah, it's very interesting. I actually had a couple of patients this week that had broken heart syndrome, Takotsubo cardiomyopathy, and it's interesting for sure how emotional things and stress can trigger cardiac problems, and how there's like
Oh
that
yeah.
deep psychosomatic thing that can happen, you know? Yep.
And cortisol.
Mhm.
It's so funny how I think a lot of people with high risk jobs walk around just in a state of excessive cortisol simply because we live in fight or flight,
Yep. Yeah.
right? And I think when your heart breaks, and you talk about that syndrome a lot, I think the cortisol levels are so high because it's fight or flight. Like you're in emotional distress, and I think that adds to it as well. It's just very
Yeah,
fascinating.
it totally is. So for these post preeclampsia moms, what are there screening guidelines or best practices for primary care
Yes.
or cardiology providers? What can we do?
Okay, so the first thing is ask the
Okay.
questions, right? So, unfortunately, in primary care, we have 15 minutes to assess you, to refill your meds and treat your problem. And so, a lot of times it slips by,
Hmm.
right?
Hmm.
So, asking the question is the number one thing. So, looking and seeing that she had it and then assessing her as a female, she actually has some different cardiovascular risk factors. But then we need to like educate them, and then we need to screen for hypertension, lipid disorders, type 2 diabetes, and talk about lifestyle things such as decreased alcohol and increased exercise. So of course they call that cardiometabolic
Hmm.
screening, and then kind of monitor for early signs of stroke or heart disease and kind of really talk about that a lot. There are some calculators that you can use for preeclampsia and for cardiovascular risk
Hmm.
factor that the preeclampsia is in. So if they put those into your questionnaire, that can really help identify those at risk.
Yeah, that makes sense. And that's just an easy way to do it too. For patients, when they are getting ready for appointments, they have to do all these questionnaires up front. And so once they do that, it's like automatic. And that will definitely make that a flag for you as a provider to be able to talk about and discuss.
Yeah, and I wanted to add this for older
Mhm,
women. One of the clinical practice guidelines said if you're over 40 to 45, and of course this is based on evidence, you need to have an annual blood pressure
mhm,
screening. You need a lipid profile every 4 to 6 years, of course, sooner if it's higher. Fasting, glucose or A1C, your BMI and waist circumference. And waist circumference is a little bit better of an indicator than BMI because we know we can have a lot of good muscle
yep,
mass and our BMI can be
mhm,
elevated. Lifestyle counseling, aspirin use. If you're high risk, according to the American Health Association guidelines, cardiac imaging, if they have any dyspnea, if they have dyspnea or difficulty
mhm.
breathing, it could be from cardiomyopathy, and of course, a referral to cardiology. We need to get them out of family practice and get them into, primary cardiology or wherever they need to be so that they can be well
Right.
managed.
I think that's the key right there is even I am never offended by and I know if any of my patient care coordinators are listening, they're going to be rolling their eyes at me. I'm never offended by a referral to us for anything for the first time, because even if it's something, and I don't say this like, but like for palpitations, like someone else, like general cardiology or primary care, could have gotten a monitor and could have like seen if there was actually an arrhythmia. Because when they come to us as a subspecialty, it's more like we're either going to manage a high risk medication for them or we're going to do a procedure. General cardiology can manage like basic arrhythmias. So sometimes when we get these like palpitations, we're like, is there anything actionable for us to do? Like, but I think of it as like it's a touch point for us to educate patients on what our subspecialty is and what their risk factors might be. And then I can send them back to general cardiology or their primary care. And then if they have more concerns later, then they can always be referred again. For me as an NP and someone who I remember, one thing that stuck in my brain from nurse practitioner school was like the biggest litigious thing for nurse practitioners is that we don't refer enough, like lack of referring.
Yes.
Which is why I'm never offended by someone referring to us, because it's better to have our eyes on it, to look at it and say, nope, this is totally normal. We can discharge you from electrophysiology, than to have them stay in primary care and never get seen and really have a problem. So
yeah, I really think so. I'm a big scope of practice person. So I am very adamant about know your scope of practice and when to refer. And because our scopes are different for different specialties, right? And for family practice. So we have to really, really know and make sure that we're cognizant. One other thing I wanted to say was on lifestyle counseling, counseling, diet, exercise, and alcohol we talked about, but smoking cessation, vaping cessation. So, a lot of vapes, there's so much vaping and they have nicotine, which of course can cause some vasoconstriction. And so really you have to be on top of your game and you have to say not just smoking, but vaping.
Yeah, absolutely. That is definitely a big thing. Like, because people think they're not smoking cigarettes, that they're okay, but vapes, I mean, I could have a whole podcast on that.
Just that one topic.
Right.
Yes, for sure.
Because it's definitely dangerous. And it really is like, I know this is, I'm a nurse practitioner, you're a nurse practitioner, and so we come from that perspective
mindset.
Where, we look at everything holistically. So it's like all these little pieces that come in together, like, the psychiatric, the lifestyle, the actual pathophysiological medical part. Like, it's your body and your life is a whole picture. And so
absolutely
we have to keep that in mind.
And again, you're your best advocate for your health.
Absolutely. After all of that, we kind of went over what preeclampsia is, what the signs and symptoms are, what the treatments are, what to look for postpartum and in the future as we get older. But what's one piece of advice that you wish every woman knew when it comes to her heart health, especially after preeclampsia?
Okay, so I made this one kind of run-on sentence because I say it all the time. Your history of preeclampsia increases your risk for future heart disease. You need to monitor your blood pressure, cholesterol, and glucose, and maintain healthy lifestyle changes. And let's work on these issues together and focus on prevention.
Love it. That is the most beautiful and perfect thing you could say. Are there any resources that you would recommend for those wanting to learn more about preeclampsia?
Well, I have the best resource, the American College of Obstetricians and Gynecologists. We call them ACOG. You can go to that site and look up patient information on preeclampsia. They have easy to read patient handouts that have all the education pieces, all the warning signs, all the treatment, all of those things that the patients can read. They also have clinician guidelines too. So they have both of them. So you can provide that resource to patients.
That's awesome and amazing. And I love that you said it's, they have like stuff for clinicians too, because, while pregnant women are not the majority of my patients. I do have some. And so this is good for me to know as well. If there are any nurses out there or nurse practitioners or any kind of healthcare provider out there that would even see a pregnant patient, like this is something that you should be aware of, because even if you don't treat it or diagnose it, you can see a warning sign and you can send them to the appropriate provider.
Right. So if you look at the statistics for how many women have preeclampsia during pregnancy, and again, they go up and down, but up to 20% is like a generalized number. If you think about that, and you're a clinician and you see 5 patients that day, or you see 5 patients that hour, really? But you see 5 patients. One of those patients, if they've had a child, if being that all given factors are the same, they've all had children, one of them had preeclampsia statistically.
Yeah, that's wild. That's a lot of
So you have to
preeclampsia.
run that through your brain.
Yeah.
Yeah, you have to run that through your brain every time you're seeing your
Yeah,
patients.
absolutely. So finally, if someone wants to connect with you or follow your work, where can they find you? How can they reach out to you?
Well, I am at the University of North Florida in Jacksonville, Florida. My email address is jabaker@unf.edu. I have some publications online. I've done some things with hiking. I've done some women's health things. So I've written a couple things. I've done some presentations. I did, things about screening for cervical cancer, and I've done a lot of different things in the women's health arena. So you can find me online. Just type in my name, Julie Baker Townsend, and you'll see some of my work. So feel free to email me. I don't have like a website. I don't have, anything like that, but, you can always reach out.
Yeah. Well, Julie, thank you so much for being with me today and for discussing preeclampsia. Your expertise is incredible, and I appreciate it. And I'm looking forward to more episodes with you.
Sounds wonderful. Thank you for having me, and I'll be listening to get some further cardiac education from you.
Thanks, Julie. Thanks for tuning in to this episode of In the Loop with Nadja Wlasiuk. I hope you found today's discussion insightful and empowering. Feel like diving deeper into the topics presented today? Be sure to check out the show notes for references and more helpful information. You can also visit our Substack or Instagram, Facebook, and TikTok. Remember to stay curious and stay informed. Now you're in the loop.